3 lecture sessions back to back can drain anybody. Even if I was sitting there, I would been half asleep by now. So I'll try to make this discussion short as well as practical, short and simple. I'll be giving emphasis on the theory aspects of CAP as well as the HAP. So when you come to the definition, as all of you know, community-acquired pneumonia pneumonia is broadly classified as per the 2005 IDSI guidelines to community-acquired pneumonia as well as nosocomial pneumonia. And the nosocomial pneumonia is again subdivided into hospital-acquired pneumonia, ventilator-associated pneumonia, and the healthcare-associated pneumonia. You all know about the definitions. Anyway, I'm just repeating it. Community-acquired pneumonia is pneumonia that occurs outside the hospital setting or within 48 hours of hospital admission. Whereas hospital-acquired pneumonia is that which develops after 48 hours after hospital admission and not incubating at the time of admission. Whereas ventilator-associated pneumonia occurs more than 48 hours after intubation and mechanical ventilation. So, what is healthcare-associated pneumonia, H or HCAP? HCAP is a pneumonia occurring in a non-hospitalized patient who had significant contact with the healthcare system, such as hospitalization for more than 2 days within the past 90 days, residence in a nursing home or long-term care facility, recent IV antibiotic therapy, chemotherapy or wound care within the past 30 days, home infusion therapy like TPN, antibiotic therapy or the dialysis clinic attendance. So this is healthcare associated pneumonia. So this definition seems to be too long, but don't worry. The importance of this definition is that these patients were thought to be at a high risk of MDR infection with the MDR pathogens. But many of the patients did not have the MDR pathogens. And studies have shown that it led to the overuse of antibiotics and no mortality benefit associated with this definition. So HCAP was finally eliminated in the 2019 IDSA guidelines. So be happy, you don't have to learn about the definition of HCAP. Just learn about CAP, hospital-acquired pneumonia, as well as ventilator-associated pneumonia. So we will start with our community-acquired pneumonia. Community-acquired pneumonia, as all of us know, the patient is not hospitalized, no hospital setting. So the pathogenesis is that the patient is having an inadequate immune response because of comorbidities, because of the anatomical abnormalities or the illness-associated immune dysfunction. The patient is having some immune dysfunction, or the patient is having an adequate immune response, but the inoculum size is very high, or the virulence of the pathogen is very high, or the patient is unable to mount an adequate immune response against the pathogen. These are the main mechanisms of community-acquired pneumonia. So what is the route of entry of this organism into the lower respiratory tract? Most common is the aspiration of the infected oropharyngeal secretions. This is the most common mechanism. The second one is the inhalation of organisms. That examples include viruses, Legionella, Mycobacterium, heterogeneous dissemination from distant sites, as well as direct extension from the contiguous sites of infection, such as liver abscess, subdiaphragmatic abscess, splenic abscess, intra-abdominal abscess, etc. So etiology, we all know about the etiology of community-acquired pneumonia. The common organisms, most common one is Streptococcus pneumonia, H. influenza, as well as Moraxella catarrhalis, and some atypical bacteria are also common causes of community-acquired pneumonia. That includes Mycoplasma pneumonia, Chlamydia, as well as Legionella, and organisms such as Staph aureus, gram-negative in some cases, or Mycobacterium viruses can also cause community-acquired pneumonia. So the severe community-acquired pneumonia may be caused by Staph aureus or endemic gram-negative organisms, and certain risk factors such as elderly patients with aspiration pneumonia, underlying cardiopulmonary illness, they may be infected with the endemic gram-negative organisms. And mixed bacteria as well as viral infections are also common, which is associated with a prolonged hospital course, increased morbidity as well as mortality. And as you know, the community-acquired variants of MRSA can also cause community-acquired pneumonia. It can occur as a complications of influenza in patients who had influenza infection. So the risk factors for MRSA or Pseudomonas include, this is very important, these risk factors are as per the IDSA guidelines, that is a prior respiratory isolation of the MRSA or Pseudomonas from any culture that includes sputum or the tracheal aspirate or the bowel within the last 1 year, and the recent hospitalization, that is within 90 days with the receipt of parenteral antibiotics. These are the two important risk factors for the MRSA or Pseudomonas in community acquired pneumonia. Now we come to the severity score in community acquired pneumonia. I am dealing only with the important relevant points only. So severity score in community acquired pneumonia, the purpose is to decide the site of care, where the patient should be cared for, whether it's in the OP setting, whether it's in the hospital or in the ICU. What about the mortality risk? How much is the mortality risk for this patient? And the need for ICU therapy, ICU monitoring or aggressive ICU care. This is the purpose of severity scoring. And the most common, a lot of severity scorings are available, like the CURB 65 scoring, pneumonia severity index, as well as the severe community acquired pneumonia as per the IDSA guideline. So most commonly used one is the CURB 65 score. So what is CURB 65? CURB 65 stands for C for confusion, U for uremia, that is blood urea more than 20 mg per deciliter, R for tachypnea, respiratory rate of more than 30 per minute, low BP, that is systolic BP less than 90 and diastolic BP of less than 60, and 65 stands for age more than 65. So each one is given a point of 1, and as per the total scores, it has been classified and categorized into various risk groups, risk group 1, 2 and 3. So risk group 1 means the patient can be managed as a OP setting, the home therapy only is needed. Risk category 2 means the patient needs hospitalization. Risk category 3 means additional ICU care may be needed for that patient. This is CURB 65 score, the most widely used prediction score and the most practical bedside tool also to decide where to treat your patient, whether it is in the OP or in the hospital or in the ICU setup. The disadvantage is that it does not include all the practical points such as the comorbidities or the oxygenation, which can significantly affect the patient mortality, morbidity as well as the mortality. So it's mainly used as a triage tool. And second one is the pneumonia severity index. It uses 20 variables. When compared to CURB 65, it uses 20 variables like the demographics, the comorbidities, the physical examination findings, and some laboratory findings also. So according to the presence or absence of these variables, the patient has been divided into 5 risk classes, and the mortality is also assigned in each of these classes. So for example, in class 1, if the patient belongs to the class 1 or class 2, the patient can be managed as an outpatient. Then class 3, outpatient, or sometimes a brief short period of hospitalization may be required. Class 4, inpatient, and class 5, inpatient. Sometimes patient might require ICU management also. It has got a strong mortality, strong evidence for the mortality prediction. That is the advantage of pneumonia severity index. And the disadvantage, as you can see here, it is very complex. It cannot be used as a practical bedside tool. It's a complex one. And also you can see that if a young patient coming with a hypoxemia, that can underestimate the mortality. If you see the table, you can see that can underestimate because it's a young patient. SPO is not included. So young patient with a hypoxemia, the mortality may be underestimated with the pneumonia severity index. Next one is severe community acquired pneumonia. This is the definition given by the IDSA as per the 2007 guidelines. And as per this guideline, at least one major or at least 3 minor criteria should be there to classify a patient as having severe community acquired pneumonia. And the major criteria, it's very easy to remember: hypotension or mechanical ventilation. These are the major criteria. At least one criteria should be there, or 3 minor criteria, and that include tachypnea, low PF ratio, multilobar infiltrates, confusion or disorientation, uremia, that is blood urea nitrogen more than 20 mg per deciliter, leukopenia, thrombocytopenia, hypothermia, and hypotension requiring aggressive fluid resuscitation. This is the definition of severe community acquired pneumonia. But I should tell you something. If you refer multiple textbooks, you may be able to find different definitions for severe community acquired pneumonia. This is the definition given by the IDSA 2007 guidelines. So, about the diagnostic evaluation of community acquired pneumonia, as with any other type of pneumonia, the diagnosis comes from history, physical examination, findings, microbiology, and the radiological examinations. So we will start from history as well as physical examination. I just wanted to keep it short. That's why I have included the history as well as the physical findings. Then routine blood work is also needed as assessment of oxygenation by doing an ABG, and blood culture. Blood culture can also help you in a patient with a severe community-acquired pneumonia, but it's not routine as per the EDSET guideline. It is indicated in patients with a severe community-acquired pneumonia or being empirically treated for or has a history of infection with MRSA or Pseudomonas, and a history of hospitalization and has received the parenteral antibiotics in the preceding 90 days of admission. If you see carefully, these are the risk factors for the development of MRSA and Pseudomonas. So if the patient has got any one of these criteria, we have to send a blood culture. So if the patient is having a significant pleural effusion, just do a pleural effusion tapping. Sputum gram stain, the role is controversial actually, but as you can see, it's neither specific, it's neither sensitive nor specific, but it can correlate with the sputum culture. If both show the same pathogen, you may be able to find out the predominant pathogen if you do a gram stain examination. Or you can, it also can help you to find out the unsuspected pathogen, gram smear. What about sputum culture? If you are suspecting drug-sensitive organisms or unusual pathogen, and the guideline, IDSA guideline, the same as that of blood culture. Recommendation is the same as that of blood culture. Serological testing for Legionella, Chlamydia, Mycoplasma, and the viruses can also help you in identifying the organism. But the serological testing is accurate, but it needs convalescent titers taken 2 to 4 weeks apart. So it's not easy to do serological testing. Then urinary antigen for Legionella and pneumococcus, and bronchoscopy only in patients who are immunocompromised or who are not responding to the standard treatment. You can consider bronchoscopy. Procalcitonin, we will come to that. Procalcitonin is not recommended for initiating the therapy, but it can help you to de-escalate the antibiotic therapy. Okay, so what about imaging? Imaging you can do, you can consider chest X-ray, CT scan as well as lung ultrasound. But it's the purpose of imaging. Why do you want to do imaging for the patients with community-acquired pneumonia? To confirm the presence of pneumonia and to characterize the pattern, whether it's lobar or whether it's bronchopneumonia or interstitial pattern, to assess the presence of complication, whether the patient is having complications or what is the complication like effusion, abscess or cavitation, and monitor the response to treatment or to detect alternative diagnosis. So chest X-ray can show you a new infiltrate or a consolidation. The findings include lobar consolidation, which is classic for Streptococcus pneumonia. Multilobar infiltrates may be there, which may present severe community-acquired pneumonia, possibly due to Staph aureus gram-negatives. Interstitial pattern, as you can see in patients with atypical pneumonia, viral pneumonia, cavitation, such as in Staph aureus, Klebsiella, anaerobes, and sometimes pleural effusion also. CT scan should not be a routine. CT scan can be used to confirm the diagnosis or detect complications and to rule out mimics of pneumonia. And the lung ultrasound, we all are experts in lung ultrasound, so I'm not going to the details of a lung ultrasound. We can show the findings, or you all know, which Rett sign, hepatization, all the other signs of lung ultrasound. It's a bedside tool. It's very helpful in pregnant patients to avoid the radiation exposure. The problem is, it's very much operator dependent. So what about the treatment of community-acquired pneumonia? So treatment of community-acquired pneumonia, you come to a diagnosis, you assess the severity of pneumonia, and then you decide upon the empirical treatment. The empirical treatment based on the severity of illness and the likely pathogen you anticipate in a particular patient. All the patients should be treated with antibiotics against drug-resistant pneumococcus as well as atypical coverage. And coverage for Pseudomonas as well as MRSA should be given only in selected patients at a high risk of having MRSA as well as Pseudomonas. All patients admitted to the ICU needs a dual coverage with a beta-lactam plus macrolide of fluoroquinolone. Macrolide, as you know, has got an addition and inflammatory effect. I'm not going to deal with the OP management. We are not interested in OP management. If the patient is hospitalized, patient is not in ICU, no MDR risk factors, then as I said, it's beta-lactam plus a macrolide should be sufficient. Ideally, we can consider azithromycin. Then a hospitalized patient, no ICU, but patient is in ICU, no MDR. Then means beta-lactam like a ceftriaxone, cefotaxime, ampicillin gentam, sulbactam, ceftriaxone plus a macrolide or a fluoroquinolone can be considered. If the patient has additional risk factors for MRSA or Pseudomonas, you can consider adding antibiotics against MRSA like linezolid or vancomycin. And Pseudomonas, when you are suspecting Pseudomonas, you have to change the beta-lactam to piptazine tazobactam or cefepime or meropenem rather than ceftriaxone or cefotaxime or ambisulbactam. And the duration of antibiotic is actually controversial. Anyway, it should be treated for a minimum of 5 days. And the IDSA ATS 2019 recommendation says that it should have to treat the patient for a minimum of 5 days, provided the patient is clinically stable. How do you say that the patient is stable? The criteria for antibiotics therapy, stopping the antibiotic therapy is febrile for 40 to 72 hours, hemodynamically stable, able to take orally, no signs of clinical instability, and the patient is mentally okay, mentally alert. Then you can consider stopping the antibiotics. Longer duration of treatment may be required in certain conditions such as MRSA pneumonia, Pseudomonas, certain complications like lung abscess or necrotizing pneumonia, extrapulmonary sites of infection, immunocompromised patient, and slow response to antibiotic treatment. In those cases, you have to consider longer duration of antibiotic treatment. So, adjunctive therapy, just for the sake of completion, you have to write in your theory papers, that is chest physiotherapy, bronchodilator therapy, aerosol humidification, as well as respiratory support. So, that completes our community-acquired pneumonia. Now, we come to the second topic, that is hospital-acquired pneumonia and ventilator-associated pneumonia. Ventilator-associated pneumonia is actually a subset of, can be considered a subset of hospital-associated, hospital-acquired pneumonia. The pathogenesis, as you know, the most important pathogenesis, the most important genetic mechanism of ventilator-associated pneumonia or hospital-acquired pneumonia. I'm considering both these as together because the main pathogenesis, the diagnosis, the treatment are all similar for hospital-acquired pneumonia as well as ventilator-associated pneumonia with some differences only. So the pathogenesis is the most important pathogenesis is the aspiration of the colonized oropharyngeal secretions. That's the most important mechanism. So what's the reason for, what's the source of this colonization of oropharyngeal bacteria? It can be endogenous or it can be exogenous. So immediately after hospital admission, the patient's oral flora rapidly changes to gram-negative organism. The colonizer starts growing inside the oropharynx. And when these secretions, when they track down to the lower respiratory tract, it can lead to the development of ventilator-associated pneumonia. The bacteria can also form biofilms inside the endotracheal tube that can act as persistent colonizers. Okay. So that is the source of endogenous cause of ventilator-associated pneumonia. And what is exogenous cause? As you know, it's contaminated equipments, the ICU environment, hands of the ICU staff, water supply, humidifiers, nebulizers, all these contaminated equipments can cause colonization. So this is the most important mechanism, aspiration of the colonized oropharyngeal secretion. So what are the other mechanisms? So, okay, some other risk factors for colonization and aspiration are there, like presence of comorbid like diabetes, COPD, alcoholism, elderly patients, those patients with disabilities, those patients who are unable to cough out the secretions, extensive use of antibiotics. These all can lead to overgrowth of bacteria, colonizers in the oropharynx. Nasotracheal intubation can cause sinusitis that can again act as a risk factor for colonization. Then alkalization of the stomach induced by our acid suppressive agents, as well as reflux, then impaired cough mechanisms, reduced mucociliary clearance. This all can lead to the development of colonization as well as aspiration. So other mechanisms include hematogenous spread from distant infectious focus, contiguous spread, inhalation of the contaminated aerosols, and direct inoculation during the procedures. These all are risk factors for the development of ventilator-associated pneumonia. So the common pathogens include the gram-negative bacteria such as the Acinetobacter. As you can see here, as everybody know that the ventilator-associated pneumonia or hospital-acquired infection are more associated with more drug-resistant organisms when compared to our community-acquired pneumonia. So gram-negative organisms include Acinetobacter, Pseudomonas, H. influenza, Klebsiella, and gram-positive organisms such as Staph aureus, both MSSA as well as MRSA, and other organisms such as Legionella and Aspergillus also can cause ventilator-associated pneumonia. So certain organisms are potentially MDR, such as Pseudomonas, MRSA, Acinetobacter, Stenotrophomonas, Burkholderia, Klebsiella are potentially drug-resistant, whereas certain organisms are sensitive also, such as Streptococcus pneumonia, H. influenza, MSSA, antibody-sensitive Enterobacteriaceae also. And certain comorbidities can also predispose the patient to the development of infection of the certain organisms, such as in patients with COPD, may be infected with H. influenza, Moraxella, Pseudomonas and Streptococcus pneumonia. And the patients with ARDS, multiple infections are possible in the same patient with ARDS. Also, Staph aureus, Pseudomonas, Acinetobacter infections are also possible. In patients with trauma and neurological diseases, Staph aureus, H. influenza, pneumococcus can cause infections. So this is one of the point I would like to stress upon in this class. That is the classification of the pneumonia. This early versus late VAP classification is based on the time of onset of pneumonia after intubation. It's classified into early onset as well as the late onset ventilator associated pneumonia. If pneumonia develops within 4 to 5 days of intubation mechanical ventilation, then we call it as early VAP. And if it develops more than 4 to 5 days of intubation, it's known as the late VAP. The importance of this is that the distinction is important because it was thought that the early VAP associated with the drug sensitive organisms and the MDR organisms caused the late ventilator associated pneumonia. And this distinction also helped in the selection of empiric antibiotic choices. But this early versus late VAP concept is now de-emphasized or going out of favor because the blurring of the microbial pattern. Now we know that even early VAP can be caused by multi-drug resistant organisms. And now the risk factor based empirical treatment is more precise. The individual patient risk factor is more important than the classification into early and late VAP. The evidence is also limited. So nowadays the guidelines are going away from this classification of early versus late ventilator associated pneumonia. Diagnosis of VAP, as I told you, is mainly based on clinical, radiological and microbiological criteria. We'll start with the presence of a new or progressive radiological infiltrates plus at least 2 of these criteria, that is febrohypothermia, leukocytosis or leukopenia and purulent secretions. We can start from there by starting from the clinical and the physical examination, laboratory findings. If you can find out this, if you can suspect the patient as having at least this criteria, you can start from you start your diagnostic techniques from here. Okay, now we need to know about the clinical pulmonary infection score. This is the clinical diagnosis of VAP can be made using the clinical pulmonary infection score. So it helps in the diagnosis as well as in monitoring of ventilator associated pneumonia. As you can see here, it is composed of different 6 variables are there. That is the temperature, blood leukocyte count, tracheal secretions, oxygenation, pulmonary radiography and the culture of the tracheal aspirate. And each one is given a score of 0, 1 and 2. And you add that total scores and come to a point of 0 to 12 points. And if you take this total score and the CPA score is less than or equal to 6, that means VAP is unlikely. If the CPA score is more than or equal to 6, then that means VAP is likely. Okay, this is the CPA score in a nutshell. So CPA score cannot be used to make a diagnosis of alone cannot be used to make a diagnosis of VAP. You have to combine it with your clinical judgment as well as other investigations and imaging. So what about the microbiology? About the sampling techniques, you all know there are 2 different types of sampling techniques can be broadly classified into non-bronchoscopic and bronchoscopic techniques. And that includes non-bronchoscopic techniques include our routine endotracheal aspirate, mini BAL as well as the blind PSB, protected specimen brush. And the bronchoscopic techniques include bronchial valve lavage, protected specimen brush as well as the protected BAL. These are the bronchoscopic as well as the non-bronchoscopic techniques of sampling. And if you take the sensitivity as well as the threshold for diagnosing the VAP, you can see that the endotracheal aspirate is having a high contamination risk, and the threshold for diagnosing VAP is more than or equal to 10 raised to 5 CFU per ml. Followed by BAL, it is having a moderate contamination rate, and the threshold for diagnosing VAP is more than or equal to 10 raised to 4 CFU per ml. And if you take PSB, protected specimen brush, the risk of contamination is very low with the PSB, and the threshold for diagnosis is more than or equal to 10 raised to 3 CFU per ml. And here also gram stain, you can do gram stain, you can do culture with the respiratory secretion. Gram stain can be used to detect the bacteria, yeast cells in the respiratory secretion. It can be used to identify the predominant pathogen. And culture should be ideally taken before you start the antibiotics, and the culture is reported as qualitative and semi-quantitative and quantitative culture reports. As per the IDSA, a non-invasive sampling with a semi-quantitative culture is recommended. So if you go to the guidelines, IDSA guidelines, I know this is a busy slide, but I will try to make it simple. Always try to get the culture whenever feasible. Whenever feasible, before you start the antibiotics, always try to take the culture. But don't wait for the culture reports if the patient is unstable when you plan to start the antibiotics. And the preferred sampling approach, as I told you, is non-invasive sampling. So there is endotracheal aspirate with the semi-quantity culture is suggested. And if you are using quantitative thresholds, BAL, as I told you, it's 10 raised to 4. The cutoff value is 10 raised to 4 CFU per ml. PSP more than equal to 10 raised to 3 CFU per ml. And when you take the case of biomarkers, biomarkers should not be used to start or stop the antibiotics. The biomarkers include your CRP, procalcitonin, estrum-1 or serum procalcitonin can help you in combination with the clinical methods to come to a diagnosis. So you should not use the clinical pulmonary infection score or the CRP or the estrum or the PCT to decide when to start the antibiotics. You can use the PCT to shorten the duration of antibiotics when the patient's condition is improving. The lab markers include your routine investigations, CBC, electrolytes, LFT, RFT, CRP, procalcitonin, and ABG. Blood culture is a must for ventilator-associated pneumonia. So what's the advantage of taking a blood culture in the patient with VAP? Just to make you awake. What's the advantage? What's the purpose of taking a blood culture in a patient with VAP? Yeah, you can detect bacteremia, concomitant bacteremia. So any other advantage, specific advantage for taking how will it change the management? Suppose your respiratory sample is showing an MSSI, so or a drug sensitive organism, and your blood culture is showing an MDR, and that means you have to broaden your antibiotic therapy. Okay, if both are showing the same organism, then that means your respiratory sample is not showing a colonizer, it's an actual pathogen. Okay, so different aspects of taking a blood culture is there. So it's very important to take the blood culture in a patient who is having ventilator-associated pneumonia. Pleural fluid study if possible, and patient with the risk factor for fungal pneumonia, you can send galactomannan in the serum and BAL. Imaging, we have already discussed about the chest X-ray, CT, and lung ultrasound. I'm not going into the details. The only thing is that important point is that imaging is not specific in ventilator-associated pneumonia. The patient may present with a new onset infiltrate or worsening of the infiltrates. So you can take serial imaging to see whether the patient is improving or worsening. And then the empirical antibiotic therapy for VAP. This actually I already told you, it should not be based on simply based on the onset of pneumonia, whether it's an early onset or late onset pneumonia. It should be actually based on the patient-specific risk factors for antimicrobial resistance, history of recent antibiotic exposure or a history of infection with resistant pathogens, the severity of illness, as well as the local susceptibility pattern. So ideally, an antimicrobial agent with activity against Staph aureus and Pseudomonas should always be included in the empirical regimen for the treatment of ventilator-associated pneumonia. So MRSA coverage, as I told you before, is indicated in patients who have received an IV antibiotics within the last 90 days, and the prevalence of MRSA is more than 10 to 20%, or if it is unknown, and high risk of mortality. That means hypotension and ventilatory support. Then double anti-Pseudomonas coverage is indicated. Similarly, risk factors for MDR gram-negative pathogen like IV antibiotics in the last 90 days, high mortality risk, local resistance of more than 10% are unknown, patients with structural lung disease. Okay, these are the guidelines. These are taken from the 2016 IDSA guidelines. But if you refer standard textbook, you might be able to find out additional risk factors like the presence of ARDS, renal replacement therapy, before the development of VAP for MRSA pneumonia, and chronic steroid administration for double anti-Pseudomonal coverage also, like that. So this has been taken from recent IDSA guidelines. So what are the anti-Pseudomonal drugs you will consider? That includes piperazine, anti-Pseudomonal beta-lactam include piperazine, tazobactam, cefepime, ceftazidime, meropenem, and imipenem, and aztreonam if the patient is beta-lactam having beta-lactam allergy. Second line, aminoglycosides and fluoroquinolones. Only as a last resort, we will consider colistin as well as polymyxin B. So this may seems to be a busy slide, but it's very simple. If the patient is having a low mortality risk, that means no MDR risk factors, no MRSA risk. In that case, just no MRSA coverage is needed. Only single anti-Pseudomonas agent is required in that case. So in the example of such regimen include piperazine tazobactam or cefepime or levofloxacin or meropenem. And always use local antibiogram to guide your antibiotic choice. If the patient is having MRSA risk, along with that you add vancomycin or linezolid. Same, so single anti-pseudomonal agent is required. If the patient is having additional MDR pseudomonas risk, double pseudomonas coverage, and MRSA coverage is optional. And if the patient is having high mortality risk, such as presence of septic shock, presence of mechanical ventilation, you give MRSA coverage, double anti-pseudomonal coverage, along with the other therapy. If the patient is having severe beta-lactam allergy, you can use aztreonam instead of aztreonam as well as levofloxacin instead of the beta-lactam. And certain additional points include the patient who have not received any anti-pseudomonal beta-lactam in the last 30 days, you can consider piperazine tazobactam or any anti-pseudomonal cephalosporin. If the patient has received these drugs in the last 30 days, consider carbapenem. As all of you know, ESBL producing organism, if it is an ESBL producing organism, always give carbapenem even if the organism is sensitive to piperazine tazobactam. Aminoglycoside should not be used as a monotherapy. And the presence of renal failure or concomitant use of vancomycin, consider fluoroquinolones. And review after 40 to 70 hours, always try to de-escalate the therapy after 40 to 70 hours, and you look for the improvement in the patient. MRSA, pseudomonas, I've already told you. That's not a bacter. You all know if the organism is sensitive to carbapenem or ambient sulbactam, you can consider these drugs. Or polymyxin B is a reserved drug, should be used only if it is indicated, and tigecycline is not recommended for the treatment of Acinetobacter-induced VAP. Duration of therapy, and IDSA recommends a 7 days course of antibiotic for VAP. If there is clinical improvement, if there are no extrapulmonary infections, and there is no persistent MDR or XDR organism with a slow response. More than 7 days treatment is required when the patient is having a slow response, complicated pneumonia, treatment with infection with bacteremia with a gram-negative organism, immunosuppressed patients, and infection with the non-fermenters. Finally, prevention of VAP, as all of us know, this is included in the ventilator-associated VAP prevention bundle. That includes strict alcohol-based hand hygiene, avoidance of tracheal intubation and use NIV if indicated. The most important risk factor for ventilator-associated pneumonia is the presence of the endotracheal tube. So try to use NIV if it is indicated. Daily sedation vacation, sedation holiday, avoidance of antiparalytic agents, no ventilator tube change unnecessarily. You all know, use silver-coated tracheal tubes, application of low level of PEEP that can reduce the aspiration of colonized oropharyngeal secretions and aspiration of subglottic secretions. Maintain the cuff pressure adequately, especially during transportation of the patient. You maintain the cuff pressure. Oral care with the chlorhexidine. Avoid stress ulcer prophylaxis in very low risk patients. Semi-recommend patient position, continuous lateral rotation therapy, and post pyloric feeding in those patients who have got impaired gastric emptying. Many of these patients, many of this is routinely included in the ventilator VAP prevention bundle, but many of this steps, the components of this VAP bundle does not have enough evidence. So let me conclude with this slide. The complications, as it is very important for the exam purpose. Complications include pulmonary complications, lung abscess, necrotic pneumonia, empyema, bronchopleural fistula, and ARDS. Systemic complications include bacteremia, septic shock, MODS, metastatic infection, and treatment related like drug toxicity, C. diff infection, ICU related like prolonged ventilation and tracheostomy. I have not mentioned the extrapulmonary complications, especially with the atypical organisms such as the neurological complications, that is the GBS syndrome, transverse myelitis, cardiac complications such as the pericarditis, myocarditis, transaminitis, pancreatitis, glomerulonephritis, interstitial nephritis. So many complications are there. I just wanted to make the slides simple. That's why I have not included all the complications. Anyway, I think I finished the topic in 36 minutes. Okay, thank you.
All right. I'm sure you're getting tired by now. So another, well, rough topic, let's say, cardiogenic shock. So why does it matter? It still has a very high mortality. mortality has, last 20 years, nearly everything in the ICU, the mortality has come down drastically. I've seen it coming down, okay, except this. Mortality for cardiogenic shock still around 40 to 50%, okay. So that's a major problem, okay. Most common cause of shock in cardiac ICU, okay, our ICU is called septic shock, okay. The commonest cause of shock overall, if you look at it, septic shock. Second most commonest probably is cardiogenic. Yeah. Very high cost. This is US. That means around 70 lakhs for each admission for if you are in the US. If you are unlucky to be in the US, if you get cardiogenic shock every time you get to the hospital, 70 lakhs goes. So, well, it's not that bad here, but it can come there if you are starting to use all your LVADs and the assist devices. Those are very expensive. It's starting to come in India. So when you start using that, we'll also start catching up there. Also, survivors have very poor quality of life. They usually have renal failure or liver failure or other dysfunctions. So they have poor quality of life generally. Okay, and recurrent admissions. So this is why cardiogenic shock matters. Okay. So what is shock? What is shock? Not cardiogenic shock. What is shock? That's shock? Hypoperfusion. Yeah. Imbalance between? Correct. That is the thing. Okay. Imbalance between your oxygen demand and your supply. That is shock. Okay. You can have shock with normal blood pressure. Okay. So please remember that it is not hypotension. All right. So here in cardiogenic shock, it is generally hypotension because there is a problem with the heart. Heart is not pumping. The heart is not pumping, your BP generally goes down, your cardiac output goes down, and your oxygen does not reach your tissues. Okay, fine. So that's what happens. So here it's due to a cardiac dysfunction. Shock due to cardiac dysfunction. All right. Generally, your blood pressure is low, more than or less than 90 systolic for more than half an hour usually can cause cardiogenic shock. Okay. Or you need inotropes or vasopressors to maintain that, or there is a evidence of hypoperfusion. That is the problem. If there is not enough oxygen, your organs will get hit. So you can get high lactate, oliguria, altered mentation, depends on which organ which is getting hit. Okay. So you can get that. So it is either or. Okay. So if you have hypotension or your organs are hit, you are still having cardiogenic shock. Okay. And classical hemodynamic cutoffs when you put a catheter is generally cardiac index of less than 2.2 and PCWP or of more than 15. Okay. Etiology usually cardiac, okay, or cardiomyopathic. The most common one is MI. MI is the most common cardiac cause, usually involving more than 40% of the left ventricle or extensive ischemia. Okay. Or if you have severe right ventricle ischemia, also you can get it, or an acute exacerbation of severe heart failure from dilated cardiomyopathy. So other than MI, then there are other things like cardiomyopathy, stunned myocardium, post arrest or hypotension or after bypass, stress induced cardiomyopathy like Takotsubo or broken heart syndrome as they say, or sepsis, advanced septic shock, of course, myocarditis, myocardial contusions, drug induced, especially beta blockers. Okay. Arrhythmogenic, you can have severe tachyarrhythmia or bradyarrhythmia that can cause cardiogenic shock, and then mechanical, basically valve rupture, valve rupture abscesses or stenosis or VSDs septal defects or acute ones that comes generally will cause cardiac failure. And usually that are also probably because of ischemia also, most of them, okay, except the valvular stenosis, of course. So what are the pathophysiological mechanisms? Usually it's either the causes are up there, either myocardial infarction or non-myocardial infarction. Both, either of them will cause it decrease when the myocardium is involved. The heart can't pump, of course, so it will decrease the stroke volume and it will decrease the cardiac output. Once the cardiac output decreases, BP comes down, your organ gets hypoperfused, and once the organ gets hypoperfused, you can see the lactate going up, and one of the organs that get hypoperfused is the heart. So again, ischemia, and it's a vicious cycle there, of course. And the other way is it can also cause vasoconstriction because of hypotension. Normally, your sympathetic activity will happen, your RAS system will get activated, and you go into vasoconstriction and fluid overload. Okay, and that will cause congestion. All right, and then once your congestion goes, your preload goes up, and then again your stroke volume, congestion, everything starts worsening again. All right, long term. Okay, and also all the organs, your brain, your liver, your kidneys, and your lungs. Of course, congestion goes into the lung also. Okay, and cause pulmonary edema. So again, pulmonary edema cause hypoxia. The whole thing goes into vicious cycle. So the whole thing can go into a vicious cycle, and after a level, you might not be able to pull them out. Okay, so act quick, act fast if you want to save them. Right, and classification. There are multiple classifications. Okay, this is from the Society of Cardiovascular and Angiography Intervention. This is stage A to E. So at risk, beginning, classical, deteriorating, and extremis. So A, B, C, D, E. Okay, right. Basically, at risk is any patient who has a cardiac condition but is not actually right now in shock. So stage B is, of course, beginning shock. So BP is low, that is systolic BP somewhere between 60 and 90, or there is hypoperfusion, that is lactate is going up. Okay, and there is no need for a device or a drug right now. Maybe some fluid, maybe some adjustment might be enough, but usually they go into the next stage, which is the classical shock, where you have hypotension or hyperperfusion like above, but you need a drug or a mechanical circulatory support device. Okay, temporary, that is the T is the temporary. Okay, mechanical circulatory device. All right, stage D is deteriorating. That means worsening of these conditions like shock and hypoperfusion, even with multiple drugs or devices. Okay, multiple devices, multiple drugs, and still patient is deteriorating. So that's stage D. And extremis is refractory, even with all this, or you have more than 3 drugs or devices and still it's not improving, or severe cardiac post-cardiac arrest situation. That's also extremis. So that's the general. Okay. All right. So you can either classify because of the etiology, so that's ischemic, cardiac, or non-cardiac. Classification by hemodynamic profiles are there. Okay, we'll come to that. The cold and wet, cold and dry, warm and wet, this thing. It also shows what happens in the, looking at the clinical situation, you can probably figure out what's going on inside, and you can also kind of figure out what treatment do you need to do depending on the hemodynamic classification. You can also look at which ventricle is affected, whether it's the left ventricle or the right ventricle or both are affected. Usually you need a PA catheter to actually figure out that. You can also look at the risk factors for these patients, frailty, baseline, other organ dysfunction before, then they have very high risk of mortality. Post cardiac arrest patients, with especially with the brain dysfunction, definitely poor outcomes. I told you outcomes 40 to 50% will die. Okay, so these are the guys who die. So acuity and dynamics, whether it's acute or somebody who had a problem developing a new one, or a progression of a old or congestive cardiac failure. And then biochemical modifiers are also there, whether there's a non-cardiac organ failure is there, inflammation. This can also cause inflammation, also gut translocation, and cause cirrhosis also. Okay, so that is also possible in the long run. So again, another classification. I think we will not go through all the classification. I think I've gone through this. So I think this will do that. Okay. So one of the major things for cardiac failure is that you need to diagnose it, act fast, of course, and diagnose it quickly. If you don't diagnose, you miss the bus. Okay, so major thing is emergency recognition of cardiogenic shock, and investigation. Usually, you need a early 12 lead ECG, of course, to whether the major cause is MI now. So we have to rule out the MI first. You need to get a chest X-ray to look at pulmonary edema and other things. Labs to look at LFT and the RFTs. ABG, of course, to look at lactates and the pH. And then most important, of course, is point of care ultrasound, which will guide you through your diagnosis as well as for your management. If necessary, your ABC. Then the next thing that will come is your airway breathing circulation. And many of these patients might need ventilatory support. NIV, maybe you can get away with some, but in proper shock, usually you need to get them intubated and ventilated. And many of them, of course, the next one is the circulatory support. So vasopressors will be what you start with, and then you can think of going up. Right. So yeah, hemodynamic assessment, something else that is kind of going out of critical care, but is actually very useful in cardiogenic shock, is PA catheter. Okay, PA catheter is, I think most of the other shocks that we have in especially septic shock, we do not use PA catheter anymore as often, at least as they used to before. We'll come to that. There was a trial where you looked at PA catheter and then found out there was no mortality benefit PA catheter. That's why it went off. But then in this subset, in cardiogenic shock, there is a role for PA catheter. It can look at which where the problem is. Is the left ventricular, right ventricular, or by this thing, and it also can guide you with the choice of if you're planning for devices, and also guide your medications. So in cardiogenic shock, there might be a role for either PA catheter or something less invasive like the PICO. Okay. So hemodynamic monitoring can be a little more aggressive in cardiogenic shock than what we typically do. There is a new study going on PA catheter in shock, in cardiogenic shock. So let it come out. So hemodynamic targets, generally you want to keep a MAP of around 65. That is general. Your cardiac output should be more than 2.2, lactate clearance, and look for adequate urine output. So these are the general things that you are going to look for. So here is, okay, it's a bit small there. I don't know whether you can see. These are the biomarkers I wanted to show you. Lactate, you know how to do. So other thing is SCVO2 or SVO2. Because again here, because it's a cardiac output problem, your SCVO2 or SCVO2 will come down. Okay, unlike in a septic shock or other shocks where it might not go down so much. In a cardiogenic shock, when your SCVO2 goes down, then you know there's a problem. Okay, so here is another thing where in septic shock, I think SCVO2 is gone out now. We don't do it anymore so much. But in cardiogenic shock, it can still be very useful. So if you have a central line in place, looking at an SCVO2 will help you guide your therapy. ABG, serum creatinine, STLT, I think we gone through that. I think this. All right. So you've gone through this thing, you've diagnosed your VAP, you started treatment. So what is your priority? What are you planning to do? Two things. Treat the underlying cause. Okay, if you can correct that, you have the best outcomes. If you can correct the underlying cause. And then of course support the perfusion. So how are you going to do these two things? The best outcome usually is in when a team effort comes. There have been lot of work going on that. A shock team which usually involves everything from the emergency medicine to anesthesiologist, basically cardiac anesthesia, cardiac surgeon, the cardiologist, the intensivist, everybody working together to get the quick optimization of these patients do have the best outcome. Okay, easier said than done, yeah, but yeah. So treatment wise, as I said, fix the problem first. Okay, and the major problem is definitely MI, and if that MI is causing your cardiac failure, very high recommendation, class 1 recommendation that culprit region should be opened up. So it came from this trial called the shock trial, where they looked at around 300 patients. They divided these patients to opening up the lesion and medical therapy, and there was definitely definite mortality benefit whether the patient, whatever the patient, okay, in respect to age, sex or diabetic status. If you open up, there was a benefit. But then there was also a confusion. Many of these patients have multiple blocks. Should you open everything up, or should we just open up the one that is blocked? So there's this other shock trial, that was the culprit shock trial which happened. They looked at, in that trial, what they found out was open just the culprit. If the patient is in shock and you're taking the patient for cath, just open up the culprit lesion, stabilize the patient. You can do the rest of it later. Okay, when you did that, only the infarct related artery, there was significant reduction in 30-day all-cause mortality, and also reduction in renal replacement therapy for this patient. So definitely, so if your patient has an MI and is in shock, get them into the IC, get them into the cath lab, open up that vessel, only that vessel, not all the rest. Okay, once the patient is stable, you can go and open up the rest. All right, so again, specific treatment, myocardial infarction, ideal one is definitely to give the culprit lesion or surgical. The shock trial actually looked at surgical intervention also, either surgical or cath based. Both showed benefit. So you can do both depending on the situation. Okay, but mostly the surgical things have come down after this thing. Everything has gone to the cath lab. Okay, that's what happened actually. Then myocardial infarction related acute mechanical complication, usually you need early surgical correction, surgical intervention as quickly as possible, and it needs to be done as quickly as possible, because usually by the time, if you will not be able to wait for a day or the night. Usually you need to get your cardiothoracic surgeon at the night and pull them down and get the patient to the OT, within an hour or two, as soon as possible. So it can be done. It can be done if you have a good surgical team and backup. It can be done. Massive pulmonary embolism, I think we just finished that. So I'm not going to go through embolism. Okay. So valvular disease, you can have interventional valvular repair or surgical repair. And arrhythmias, of course, you can correct it by either medications or electrical. And then very rarely for autoimmune cardiomyopathies, maybe immunosuppression, but that's not very common. Okay, very rarely we use that. Okay, So that's there. Pharmacotherapy. What are the drugs that we need to use? First and foremost, many of the drugs that you use for cardiac failure, who patient is on cardiac failure and comes in. What are the drugs that you use? Yeah, beta blockers, SGLT2 blockers, AC inhibitors, right? All of them will worsen cardiac failure, cardiogenic shock. Stop that. So patient is in shock. Most of these drugs has to be looked into and stopped. Okay, so that's something that you need to do. And of course, you need to start them on a catecholamine release. How will you do it? You give it the lowest possible dose to give the MAP. So please understand, catecholamines are bad for your heart. Okay, takes up more oxygen. It can worsen the heart. Okay, so you need to give the minimum level possible, but you need to give them, because unless you give them, they are going to die. So when you're going to die and you need to give a bad thing, use it as carefully as possible. That's it. All right. So monitor carefully, put an arterial line, and then use these drugs. Okay, so that you can titrate them carefully. Okay. So which catecholamine is the other question? What do you give? Noradrenaline or dopamine? Noradrenaline. Okay, great. You should go to the cardiologist. They give dopamine now. Okay, right? They still give dopamine. Yeah. Most of them do still give dopamine. Okay. So that's the trial that looked at the SOAP trial, but it looked at shock, not cardiogenic shock. Okay. When you looked at shock, SOAP trial showed that noradrenaline had the lower risk of tachyarrhythmias, okay, compared with dopamine, and mortality was less in cardiogenic shock patients. Okay, but the problem is it was a study with general shock, not cardiogenic shock. So this is a subgroup analysis, and it was not powered to look at the mortality in that subgroup. So okay, that thing you should take it a bit pinch of salt, but overall definitely you should use noradrenaline. Why not? Okay, because yeah, less arrhythmias anyway, and probably less mortality. The other one is whether you can use epinephrine. Epinephrine has both the uses there, vasoconstrictor as well as inotrope. So you need an inotrope also. So why not epinephrine? All right. The problem is this trial very clearly showed that there was more mortality. Okay, so epinephrine in cardiogenic shock, maybe not. First preference will go to norepinephrine. Okay, maybe you can add vasopressin if necessary, but yeah, still noradrenaline. So most patients will need it. So first line is definitely noradrenaline, and then milrinone, then inodilators are the other one, dobutamine, milrinone, and levosimendan can be used. There are studies with both. Nothing is showing milrinone, and when you compare dobutamine, not much. Please understand they are vasodilators also. So when you have to be careful when you use that. They can cause hypotension. So you have to be careful. But in the setting of cardiogenic shock, pure cardiogenic shock, very often you don't get so much of a hypotension with dobutamine, because the problem here is heart is not working. So if the heart pumps more, usually your blood pressure also starts going up. So not as much as what you see in sepsis or any other issue, but you can use this reasonably well. Okay. Definitely avoid epinephrine. Then what about mechanical circulatory support? Okay, optimal mechanical support. So optimal pharmacology therapy and treatment of underlying cardiac might not stabilize this patient. So in this patient, you can try temporary mechanical support resource. But clinical evidence for these devices are not so robust. Okay, so one that showed not so good evidence is for IABP. Okay, IABP was probably the most used kind of support that we had, but then this trial showed there was no difference in long-term survival benefit, myocardial infarction or reinfarction. Okay, so because of this trial, the IABP use in shock has declined dramatically. Okay, it used to be used quite often. Okay, what about other things? So other things are called impella. Okay, the impella is a microaxial pump. It works by the Archimedes screw principle. It's like a screw that pushes the blood out. Okay, it does unload the LV, improve hemodynamics, and there is some studies showing some survival benefit, but not fully proven yet. Okay, but it is widely used. It can be put reasonably easy through the femorals, and it can unload the left ventricle quite well. So it's something that is getting used, but the problem is the cost. It's around 40 lakhs. So other one that we have very easily available is probably the VA ECMO. Can restore perfusion, but there are high complication rates, unfortunately, more bleeding, ischemia, and the most important is the LV distension, because this one takes blood from the right side and pushes it into the aorta, right? So your afterload just goes up and you have a failing heart, and yeah, so you have a problem. The heart will start bulging, and then you need to put another thing for LV venting. So you need to put an IABP or an impella on top of that. So you have two devices now. Okay, so these are the issue with that. So, and of course the timing to take this are crucial. So okay, I've just kept some of the studies for this, but I think I will just skip through. Again, you needed the thing. I think we did talk about the Optima and the SOAP and all that. But IABP, it is the IABP shock trial which I showed, which didn't show any benefit. VA ECMO is the ELS shock and the ECMO CS study that have been shown. And for macroaxial form, there is danger shock and IMPRESS. Again, none of them shows great survival or great benefits in long-term survival. Of course, other things is just the normal thing that you should do for everybody in the ICU. Okay, protective strategies, avoid high PEEP because that can reduce the LV preload. Renal replacement should be done. Most of them have renal failure, AKI. So if necessary, renal replacement and careful fluid management has to be done. Neurocritical care, especially for post-arrest patients, many of them can come that way, and hypothermia protocols or neuroprognostication are very important. Nutrition, glycemic control, infection prevention, and most importantly, ethical care. You need to, as I said, when 40-50% are dying, you need to know who is going to die. Okay, and plan that care accordingly. Communicate with families, necessary DNR, find out what the patient wanted, the family wanted, DNR and other supportive services has to be implemented. All right. Thank you.
So basically polytrauma and ATLS updates. How would you go about this? So these are the topics that we are going to be looking at. How will you initially assess the patient? X, A, B, C, D, E, which is an update now. S bar is for communication. The lethal diamond, which was previously the lethal triad. TIC, which is trauma-induced coagulopathy. Massive transfusion protocol and damage control surgery. So we'll be going through all of these topics. So this is a scenario. You are being informed by the emergency medical team, the outside team, that there is an RTA, car versus a bike. 5 people have been injured, and this is all coming to your hospital, which is a tertiary care center. So you're getting prepared. It's probably a polytrauma. What does a polytrauma mean? So there's a definition for this. It's a Berlin definition in 2014. Basically means that 2 or more body regions have been affected, and in each of these regions, 3 or more points have been injured. In addition to this, If any one of these is there, it amounts to polytrauma, which means an elderly patient, more than 70 years of age, somebody in shock with a systolic blood pressure less than 90, somebody who is unconscious with a GCS less than or equal to 8. Now, subsequent tests might show that the patient might be acidotic with a base excess less than -6, coagulopathy, INR more than 1.4. So, if all of these, one of these things are there, injury to 2 or more points, in each point 3 or more points of injury, then we suspect polytrauma. So, you are ready to receive the patient in the emergency medical services, the roles have been assigned, there is a team leader. Now, ideally, you should take universal precautions. So, once the ambulance is coming, the patient is being brought in, the EMT services have to give you a handover. So, nothing should be missed. So, the handover is this acronym MIST. MIST basically means they should tell you about the mechanism of injury, what the primary medical complaint is, what injuries the patient has sustained, what are the signs and symptoms now, and what treatments have they given. So, in our case, 3 ambulances have come in. One ambulance has this patient who they are saying is young male. They have not been able to identify anything other than that. This is the pillion rider. So, the fellow had a helmet. He's a pillion rider. He's fallen off and he has some injury to his arm. There are some injuries to his face as well as scalp. Patient is unresponsive and in shock. So, what have they done till now? They have put a cannula in the hand that is not injured. They've tried to give some fluids. They put the cervical collar. They're trying to tie a tourniquet. This is how they brought the patient to you. So, now this patient, you have to triage because this is a case where multiple patients are coming in. You don't have that many resources to see everybody. So, triage and you have to see which patients fall in what criteria. So, red criteria basically means this is decided by the EMT itself. They have to bring the patients with the most serious injuries to the highest level trauma center. So, you are now sitting in the highest level trauma center. They've brought the patient to you. You've seen the injury pattern. The injury patterns which are seen in red triage are actually injuries to the head, neck, torso, major fractures of the head, extremities being avulsed. So, those kind of patients will come to you. Now, all patients, the mental status and the vital signs, you should check it. If the patient is in shock, if the patient's GCS is less than 6, this also falls under red category. So, this has come to you. Supposing the injury is not so bad, the injury is slightly less, but then it doesn't have to go to the highest level trauma center. It can go within the geographic constraints. It can go to whichever center is ready to receive this patient and manage accordingly. So, that is yellow triage basically. You can read yellow triage. Now, next the patient has reached you. You have to now conduct the primary survey. So, the primary survey basically means previously it was ABCDE. This X was not there. This is a recent update in ATLS 11th edition. X means manage the exsanguinating external hemorrhage. Why? Because this is the greatest threat to life. So, manage that first. If you see a massive extensive bleed with a spurting vessel which seems to be compressible, manage that first. How are you going to manage it? So, apply some pressure, pack it, apply a tourniquet. Now, this tourniquet was something that was in fashion a while ago. So people let go of it later simply because most of the time people tied it and forgot about it. So, it led to complications like rhabdomyolysis, neuropathies and subsequent even amputation of the limbs. So, now it has come back because they've realized that in hospitals they've studied when they did this tourniquet tying, if you left it less than 2 hours, it's acceptable. It will control the bleeding. There is a definite mortality benefit. So, this is how you would go about managing a patient who has got, say, an extremity which is injured. There's a spurting vessel. You tie a tourniquet. Where do you tie it? You tie it like 2 to 3 inches proximal to the injury. And you tie it tight enough that the blood does not spurt out through the injured vessel. So, that pressure is somewhere more than the systolic blood pressure. Supposing after you've tied it, it's still spurting. You can tie another tourniquet as well. Again, 2 to 3 inches proximal to the first one that you've tied. So, it's in inches, 2 to 3 inches proximal to this injury, you tie the first one, not able to control, tie a second one, even 2 to 3 inches proximal to the one you've tried before. So, you tie all these things, but most importantly, time it. It has to be less than 2 hours, it should not be more than that. And tourniquet conversion basically means once you've tied it, you've been able to achieve some amount of hemodynamic stability, then you can slowly start removing it, pack it, apply pressure, remove the tourniquet. This is what tourniquet conversion means. Now, unfortunately, if you have hemorrhage in non-compressible sites like the chest, the abdomen, if the injury is too proximal, like it's avulsed from the shoulder or something, where are you going to tie the tourniquet? It's not going to be possible. So, in these kind of patients, forget about the tourniquet. You have other methods of management, we'll come to that. So, this is the X. X is control the exsanguinating external hemorrhage, most important. Next is airway. When it comes to managing the airway, it is individualized. Depends on the patient that has come to you. So, sometimes it can range from just nasal prongs to intubation to front of neck access. So, in my patient who has come, this patient's GCS is 3. I have to probably intubate this patient. So I will practice something like cervical spinal motion restriction. Previously, it was immobilization. Immobilization means when you bring in a patient from the site of injury to the hospital in an ambulance, you have to completely immobilize the spine so that you don't change its alignment. You don't cause more damage to the cervical spine. So what people used to do, they used to put a heart collar, they used to tie them on the heart board and then bring the patient to you. A lot of the times with this heart collar, intubation and all becomes very difficult. The spine board will be left in place for a long time, causing pressure sores. So modifications have been made to the spinal motion immobilization. Now we practice restriction where minimize movements, make sure that there isn't too many jolting movements. Use the heart collar, but you can slightly loosen it if you need to. Use the hardboard, remove it as quickly as possible as soon as you don't need it. You can use sandbags also to stabilize the head. So keep the spine in alignment. Basically, that's what it means. Now, supposing the airway is blocked, they're saying you can apply a jaw thrust. Don't go for chin lift. The chin lift can cause extensive cervical spine extension, so it's mostly avoided. Now, in my patient, this patient has a GCS of 3. My patient is hypoxic. I have decided to go ahead and secure a subglottic airway. So I will practice rapid sequence intubation and keep everything ready, the difficult airway cut, and I'll go ahead and intubate this patient. Supposing the patient has had a cardiac arrest, forget about rapid sequence and all, go ahead and intubate. You don't have to give the medications then. So this picture, basically the first two shows jaw thrust, how you would apply. We know this. Second is something that they mentioned is a vice grip. Basically you keep the mask. It's essentially the same as jaw thrust. Keep the mask, push the mask down and push the, or rather lift the jaw towards the mask. Otherwise what we do is we just lift the jaw and then put the mask, right? The other way. So it's vice grip. If at all they ask, this is what it means. Put the mask first, push it down and pull the jaw towards the mask. Basically that's what it means. So another important thing is I'm trying to intubate this patient. I don't want the force that I'm applying because of the intubation and the laryngoscopy to cause any injury to the cervical spine. So I'll practice something called manual inline stabilization. For this, I need an assistant, and the assistant depends on the ergonomics. The assistant can be standing next to you, or the assistant can be on the side of the patient facing you. So what they do is, for the force that I'm applying to lift with the laryngoscope, they will apply a downward force. But the downward force should not be too much. They should not apply traction. They should not cause an injury. So it's a very fine balanced thing. So I have done the manual inline stabilization with my assistant. I have gone ahead and intubated my patient. Now, next is breathing. So we finished the exsanguinating hemorrhage part and the airway part. Next is basically breathing and ventilation. How are you going to assess this and manage this? So what they say is look, listen and feel. So as soon as my patient came in, I should have looked at the chest rise. I should have auscultated. If there was any air entry issues, I should have seen all these things. I have done the airway and all that. Now I'm auscultating. Now my patient is becoming exceedingly hemodynamically unstable. Now I'm realizing there is no air entry on one side, probably a tension pneumothorax. So other injuries that can happen to the chest and the sort of cardiac box as we call it, the injuries are hemothorax, injury to the cardiac box, flail chest, injury to tracheobronchial tree, injury to the diaphragm. All these things can happen. So supposing in my patient, I'm thinking it's now become a tension pneumothorax because the patient is hemodynamically unstable. Now I have to go ahead and manage this tension pneumothorax. What am I going to do? So you have to decompress this. Decompress it with a needle or decompress it with your finger, and after that you put a tube thoracostomy. So how would you do it? The site of doing this, the needle decompression, the finger thoracostomy, you can do it in the second intercostal space at the mid-clavicular line. So it's the yellow line which you can see. The tube, you have to ideally put it in the 5th or the 6th intercostal space, somewhere between the anterior and the mid-axillary line. So that's somewhere behind, and it is actually the location of the inframammary fold. If you can't feel it, see the inframammary fold, trace it behind, somewhere between the anterior and mid-axillary line, you will get this location, which is the 5th and the 6th intercostal space. Put the tube there. So if I'm doing a needle, it's a 14 gauge needle or a bigger needle, decompress it. There's no point in keeping the needle there and forgetting about it. You have to put a tube after that. Otherwise, it will not work. It can become a tension again. So this is how I would do it, a tension pneumothorax. Supposing a simple pneumothorax, this is a simple one, I've done a CT, the size is less than 3.5 centimeters, then I can leave it. I don't need to manage it. An occult pneumothorax is something which is evident only on higher imaging, like a CT imaging. This needs to be managed only if you're trying to airlift the patient or something. In that case, the pneumothorax will expand in size. So before airlifting, you have to put the tube and then take them off. Now in pregnant, this is a special population. You are going to have to go even 2 ribs higher. If you want to put the needle, you can put it in the 2nd space, but you cannot put the tube in the 5th and the 6th because of the gravid uterus, the diaphragm is going to be higher up. So go even above, not the 5th and 6th, slightly higher. Elderly, you'll think because elderly is slightly emaciated, it's going to be easy. It's not going to be easy. The needle might not go in that easily. the tube also it will be very difficult to maneuver it in. So sometimes you have to extend the incision in elderly patients to put the tube in. So I've put the tube. Supposing it's an open pneumothorax. An open pneumothorax is just open to the air. What are you going to do? Put a dressing which is sealed on 3 sides. Do not seal it on the 4th side, so that when the patient expires, the air should be able to go out. After I've done this, I can put an ICD. An ICD should not be put through the same space where the open pneumothorax is existing. Put it in another space. After this, definitive surgical management has to be done to close this. So supposing there is a hemothorax. When will you put a tube for a hemothorax? If you're seeing it on an ultrasound or so, and if you feel it's like more than 300 ml, it's probably going to need a tube thoracostomy. Put the tube. Previously, there were ideas about if the output from the tube was high, a certain range, then you have to go for thoracotomy. Now that concept is not there. It doesn't matter how much is coming. If the patient is in shock, if there is continued bleeding, you need definitive management. So take the patient for a thoracotomy then itself. So it's not based on chest tube output. If you look at older books, you'll see that this is not practiced anymore. So by now, somebody should have done the fast. The extended fast or the fast, I'm sure everybody knows this. So basically we're looking for free fluid, and in that particular area we'll suspect some kind of injury, and we're looking for pneumothoraxis as well. So next is circulation assessment and volume assessment. How will you go about this? So most of the time what happens is, in a case of polytrauma, assume the shock is because of hemorrhage. Most of the time they'll come with tachycardia and cold extremities. You assume that it is hemorrhage. Look at the severity. Try to gauge the severity. Is it minor, moderate or severe? So previously you had class 1, 2, 3, 4. Still, we can still learn all those things. But in ATLS, they've put this up. So basically minor means the hemodynamic parameters is sort of okay. Moderate, they start getting sick. So they'll become tachycardic, the blood pressure is falling, pulse pressure is decreasing. They'll become tachypneic, GCS is starting to fall. In a major bleeder, if you look, the base deficit is going to be less than -10 or even less than that. So they're going to be very acidotic. Here you have to realize, in the moderate bleeders, you're probably going to need blood transfusion. In the major bleeders, you'll need massive transfusion. And in the moderate bleeders, they might respond transiently to whatever fluids you give. You might give some blood products. You may not need surgery. You may or may not need surgery. You have to decide. But the major bleeders are most likely going to need some kind of surgery. So there is, in this current ATLS, they mentioned that you don't have to exactly quantify the blood loss, less than 15 to 40, whatever. You don't have to do all those things. Look at the parameters, because if you quantify and say it's 30%, it need not be. It may be more than that actually. So don't do all these things. Go with minor, moderate, severe, severity of hemorrhage basically. So patient is bleeding. You are trying to find out there's some occult source of bleeding. You're not able to see exactly. So this is another sort of a sentence is 4 and on the floor. Basically, it means the blood loss could be on the floor as well as on 4 other points in the body, which you should keep in mind if there is ongoing shock. So 4 points in the body could be in the thorax, it could be in the peritoneum, it could be retroperitoneal, and the long bones. A lot of the times we tend to forget about the long bones. Sometimes people can have isolated long bone fractures. As a matter of fact, the femur can constitute nearly 1.5 liter blood loss. The tibia as well as humerus, around 750 ml blood loss can be there and more. So never forget the long bones. So 4 points where you can look for these kind of bleeding, and look at the floor as well. So blood loss can be in any of these places. Now to manage the circulation, I have put in 16 gauge cannulas or bigger gauges. I'm giving fluid resuscitation. I'm not able to get an IV. What will I do? Intraosseous access. So they always ask this question, where will you put it? So it's a humeral head, or it is the proximal aspect of the tibia on the medial aspect, around 1 to 3 centimeters below the tibial tuberosity. That is the site where you have to put it. Now I've gotten the access. Ideally somebody should keep pre-warm fluid 39 degrees, and I'll start giving the fluid. You will need blood. If it is a moderate to major bleeder, you are going to need blood. So make sure that blood products are arranged. Now these trials, prompt and proper trial, you can go through them. They've shown balanced blood transfusions and its mortality benefit. You can go through it. In the meantime, send out blood gases, send out blood grouping, cross-matching, coagulation parameters, all these things. Now, this is a very important thing in circulation management. What is permissive hypotensive resuscitation? Basically, it has been studied in truncal penetrating injuries. They found that you limit the systolic blood pressure to 90 millimeters of mercury. There's a definite mortality benefit. This is not applicable for traumatic brain injury or a spinal cord injury. The reason why they say this is, do not give excessive fluid and target higher things. Why? This hemostatic plugs that are formed naturally by the body will get displaced. So limited to this level, this is enough for tissue perfusion to happen. But this is not a final thing. This is just a sort of thing that should help you to till the definitive control. So it's a stabilization thing. Next is, these are the types of responders. Supposing you've given fluids and you're seeing the patient is rapidly responding, the vitals are returning to stable. So this is a rapid responder. This you can manage it. It's not much of a blood loss. A transient responder will respond when you give the fluids and then again fall back. So this patient is probably going to need some blood transfusions. So alert surgeons, interventional radiologists, all these people. Non-responders, whatever fluid you give, they are not responding. You will need massive transfusion in these patients. The shock is so bad that you might have to inform the surgeon to come and actually do some damage control surgery in these patients. Suppose initially you thought it's a hemorrhagic shock. It is, you're looking everywhere for the hemorrhage, you're not able to find it. Think of other non-hemorrhagic causes of shock as well. So we are always assuming that polytrauma is associated with tachycardia, peripheries which are cold is a hemorrhagic shock. Supposing that is not the presentation, look for all these other causes of shock. So it can be obstructive. You've done the EFAST, you should be able to figure it out by now. Tension pneumothorax and cardiac tamponade are actually clinical diagnoses. You don't need the FAST to figure this out. Then in the heart, suppose there's a blunt cardiac injury, it can cause MI as well. So MI, if it is there, then the patient has to be shifted to the cath lab. That could also be a cause for shock. Distributive shock, neurogenic shock, basically it means that the efferents from the spine which are going on, the sympathetic tone of that is lost. So the parasympathetic tone sort of overrides. So because the sympathetic tone is lost, everything is vasodilated peripherally. So peripheral vasodilation, warm extremities, bradycardia. That is how these people will present. So that is neurogenic shock. Septic and anaphylactic, we are not going to come across that often, but it can be there. So supposing it's a tamponade, what will you do? An ultrasound guided pericardiocentesis, if it's possible, you can do. Supposing the patient is near arrest, then there's no point in doing ultrasound guided things and all. Do a thoracotomy, open it, drain it out and do a direct cardiac massage. Supposing the cardiac arrest, the patient has had shock. There is exsanguination happening for sure. Patient has had a cardiac arrest. Now what are you going to do? Are you going to give CPR? In this kind of patient, exsanguination in extremis, these kind of patients you give CPR, you're only going to drive away whatever fluid is there more outside. So do not give CPR, it's ineffective. Try and restore the volume somehow, give blood products. These patients might need a thoracotomy. Go in there and clamp the aorta. This is what you would do. So we've covered X, A, B as well as C. D is basically disability. Assess the neurological status of the patient. So here neurology means the patients can have two issues. Traumatic injuries to the brain and traumatic injuries to the spine. Our primary aim is avoid any secondary insults. So hypotension, hypoxia, these insults should be avoided. So check for the pupils, the motor sensory function, GCS, all these things. Now when you check the GCS, why you're checking the GCS is then you can classify the TBI. You can get an idea. So if the GCS is somewhere between 9 and 12, it's moderate TBI. GCS is less than or equal to 8, it is severe TBI. So now what happens, TBI means is a different management altogether. So previously I did mention the spinal motion restriction. The term is preferred to immobilization. This SMR actually comes under the disability because it's affecting the spine and the cords, and there should not be any deficits because of any undue motion that we create. So SMR I've already mentioned, put the collar, put the hard boards, remove it as soon as possible, as soon as you've ruled out any injuries are there, minimize any jostling of the patient. Now when do you do a CT? In my patient who has come GCS 3, I have intubated, I've done all these things, I'll probably shift for CT because the GCS is only 3. Otherwise, supposing you have a patient who has had an RTA something, is in polytrauma, has a history or an episode of loss of consciousness or some post-traumatic amnesia. With the GCS less than 15 itself, you can do a CT. And all other conditions, you would do a CT even otherwise, headache, vomiting, seizures, all of these situations, you will do it. So do the CT. Why are we doing the CT? To see if there's any bleeds, SDH, any EDH, any intraparenchymal hemorrhages, SH, all of these things. So next is, this is the Canadian C-spine rule as well as the nexus. What these mean are, supposing you're suspecting a cervical spine injury. In these patients, will you do imaging? Which patients are you going to do imaging? So supposing a patient comes to you and the patient is a high risk factor for spinal injury. What are high risk factors? An elderly person, more than 65 years. The injury mechanism is quite dangerous. Dangerous means they've fallen from a height of more than 1 meter or more than 5 stairs, or it's a high motor vehicle collision, like more than 100 km/h collision. These kind of patients and all might have sustained injury that could have affected their cervical spine as well. Or any paresthesias in the extremity, the patient itself is saying these things. So these indicate the patient might have a C-spine injury. Go ahead and do cervical spine imaging as well. So it could be CT, a lot of times need not be possible. Do an X-ray, AP, lateral and the open mouth view as well. So that is the Canadian C-spine rule. What is nexus? Nexus is the same thing. Here you see the mnemonic is NEXUS, where N means the patient's having some neurodeficit or patient's intoxicated, there's some extremity injury, unable to provide history, so you can only assume there is some injury to the spine. And when you palpate, there is spinal tenderness. Any one of this is there, do a C-spine imaging. Now, once you've realized that there is some traumatic brain injury or a spinal cord injury, you have targets that need to be met with regard to the systolic blood pressure, the MAP and all. So permissive hypotension and all cannot be done for these patients. So here in previous, this is also an update. There were some age recommendations, 15 to some 75 or something like that, in that age and less than 15 months. It's confusing. They've removed all those things. Now what they're saying is 15 years and above, if you're suspecting TBI, make sure that the systolic blood pressure is more than 100. If you're suspecting a spinal cord injury, make sure that the MAP is more than 90. So the targets are even higher for a spinal cord injury. Then everything else is more or less, you can read through all these things. This is one of the updates actually in the latest ATLS. Also the CRASH 3 trials. Why CRASH 1 is there, 2 is there, 3 is there. 3 basically in moderate to severe TBI, they've seen that within 3 hours of injury, 1 gram of tranexamic acid being given and then subsequently 1 gram over 8-hour infusion has had some mortality benefits. So supposing now my patient, I've done all these things, I'm seeing that the neurology is worsening. It was maybe the patient's GCS was say 9 or something, it's worsening. Pupillar asymmetry is there. So I can assume that there's some mass effect that might be causing some herniation or so. So I'm going to try anti-edema measures. So head end elevation, keep a neutral cervical spine position, target an ETCO of 30 to 35, not less than this. No role of hyperventilating excessively. Give IV bolus of hyperosmolar agents, target normal temperatures. So subsequently, I've done the imaging, C-spine I've evaluated, I've done all of these things, there's a bleed, I'm going to tell the surgeon, come and see. So they might decide about what to do. Depending on the size of the EDH, SDH and all those things, they'll decide on whether surgical intervention is needed or not. So they might do ICP measurement, evacuate the hematoma or even decompressive hemicranectomy. So A, B, C, D is over. E is basically exposure and environmental threats. So you have to fully expose the patient, look for any injuries, cover them quickly because it can cause hypothermia. Whatever environment they have been exposed to, that is going to affect their body. So it could be cold environments which can cause hypothermia. So you have to warm them as quickly as possible. If it's less than 24 to 28, you might even need extracorporeal cooling. Supposing they've been exposed to like a heat stroke kind of situation, temperature is going to be high, more than 37.5. In that case, cool them. Put ice packs in the major vascular areas, evaporative cooling, immerse them in cold water. So if it's more than 40.5, it's going to be even severe. Sometimes patients can be, because of these motor vehicle collisions, there might be burns also sustained. More than 20% of total body surface area burns are significant. So you will have to go about managing it in that way. So at all costs, dignity and privacy of the patient should be protected. The ATLS update this time has been all about consent, about protecting patients' dignity. So they have mentioned this over and over again. This is just something that I've just mentioned. This has nothing to do with the rest of it. Supposing anybody asks, if you have a pelvic fracture, it's a site of major collection of blood, an open book pelvic fracture, you apply a pelvic binder. Now, where would you put it? Take the bed, if you, most of the time it's a bed sheet. Otherwise, you have a binder available in the hospital. Put it over the greater trochanterus. That is the location. So that's the third image shows where you would put it. So now you've done the primary survey. So initial assessment basically means I've done the primary survey, the X, A, B, C, D, E. In addition to that, I've connected all the monitors, I've done the imaging, I've put the Foley's, an nasogastric tube, all of these things. Those are the adjuncts to the primary survey. I have reevaluated and I've done a secondary survey. Secondary survey means I'm trying to see if I have missed anything in the primary survey. So head-to-toe examination again, detailed neurological examination, and I'm going to review the CTs and everything that has been done so that I don't miss anything. That's basically secondary survey. By now, you have to figure out, does this patient need to be here? Is this patient going to be referred somewhere else for definitive care? This is initial assessment. So initial assessment is done. I have decided that I'm going to refer this patient outside from my center to some other center where they can manage some of the complications. So when you transfer, this is the acronym for the communication. S bar basically. S is the situation, A, B, C, D, E, X, A, B, C, D, E, what you've done. B is the background of the patient. The background of the patient has another acronym which is AMPLE. AMPLE basically means if you are able to elicit this history, is basically allergy, medication, any past medical history, where did they have the last meal, the events surrounding the injury. So these acronyms you need to know because there are 100 acronyms in ATLS, but these, most of the time they ask. Now, so the background, I've given the information to the doctor who's receiving it, assessment. Now, the present condition of the patient. vitals, whatever imaging I have done, I'm going to tell the receiving doctor. And lastly, recommendation. Supposing I'm airlifting the patient, there's a pneumothorax, I'm going to ask the doctor who's receiving, do you need me to put an ICD? So if they say yes, I'll put it. So recommendations and all these things have to be taken into account. This is how you would communicate if you were to refer the patient out. So now we have done with the primary survey, the secondary survey. Supposing the patient has now become stable and is hemodynamically okay, I will now do the tertiary survey. Tertiary survey is again done nearly 24 hours after managing the initial problems and only done once the patient is stable. It's simply to make sure that I have not missed anything. The CT, sometimes what happens, you'll do a CT, you'll manage the most important thing, much later on you'll realize patient has a clavicle fracture. So that happens. So to make sure that I don't miss anything, I'm going to do a tertiary survey as well. So these are the primary, secondary and tertiary surveys. Now lethal diamond. Why I'm saying this? Because this was asked. Lethal triad was what was there previously. This triad it causes mortality in polytrauma. So previously the triad did not have hypocalcemia. It's got the element of hypocalcemia as well. Somebody has got polytrauma, injured, they start bleeding. You're giving blood products. Patient's going into hypothermia. Shock is ensuing. That is causing acidosis. Calcium comes into play in this because the products that you give, the citrate is going to bind to the calcium. The hypothermia that you are creating because of the fluids and everything that you've given in the environment will affect the metabolism of citrate in the liver. So the calcium starts binding to the excessive citrate. So like that also the calcium is going to go down. All of these things combined together causes something called the lethal diamond, which is going to kill the patient. So make sure this does not happen. At all costs, this should be avoided. So warm the patient, keep on checking the calcium, correct it as necessary. Ionized calcium is what we should check. Avoid acidosis. Coagulopathy, repeated tests should give you an idea about coagulopathy. So transfusion, that is trauma-induced coagulopathy, you can read about it. They've asked this several times. So trauma can cause coagulopathy because there's tissue injury, it causes inflammation, hyperfibrinolysis like situation. Now hyperfibrinolysis is important. This comes under the category of the CRASH-2 trial. So CRASH-2 again showed that you give tranexamic acid in patients who had polytrauma, there is a mortality benefit because it is an antifibrinolytic agent. It will stabilize the fibrin clot. So give it within 3 hours, the first bolus, and then the second infusion over 8 hours. There is no role for giving it after 3 hours. It in fact increases the mortality, so it's avoided. Now massive transfusion protocol. What does it mean? If you require more than 10 units of PRBCs within the first 24 hours of admission, or you need more than 4 in an hour and you are anticipating ongoing need, or you've replaced more than 50% of the patient's blood volume in about 3 hours of admission, probably patient is eligible for massive transfusion. How do you figure out a patient who has come if this patient is going to need massive transfusion? Because if you need it, you have to alert the blood bank. So the things that need to be provided will be different. You apply something called the ABC score. It's a simple bedside tool. Look at the mechanism of injury. Is it a penetrating injury or not? Is there shock? Is the systolic blood pressure less than or equal to 90? Is the patient tachycardic? Heart rate more than 120? Is the fast positive? Everything. There are 4 things. Each of them are given 1 point each. If there's more than or equal to 2 points, assume the patient is going to need massive transfusion. Alert the blood bank. Now there is another scoring system. It's so tiny you cannot see it. It didn't look this bad on my laptop actually. So basically ABC score is one score. Another score is something called shock index. There are 100 scores. Nobody's going to remember all these things. Shock index is also there. Basically you're looking at the ratio or the heart rate to systolic blood pressure. So as the shock worsens, the heart rate becomes more and more, systolic blood pressure falls even further. So the range of the shock index is somewhere between 0.5 to 0.7. More higher, 0.7 and higher will indicate that the patient is probably going to end up needing massive transfusion as well. Learn 1 or 2 of these scores if possible. ABC and shock index for sure, maybe 1 or 2 other than that. Next is, what about if you are activating the massive transfusion? That is, I figured out the ABC score is more than 2, my shock index is say more than 0.8, there's ongoing bleeding. I'm going to have to alert the blood bank now that I'm going to need a lot of blood products. So I have to assign roles to different people. Somebody to go and get the blood, somebody to cross match and check all these things, somebody to give the blood through a warmer. So I've started giving the blood. Now if I feel like ongoing need of blood transfusion is there, I have to again send back samples. Now you have to give some blood group cross match things. They will give you plasma, AB plasma and O negative blood. Subsequently, you are going to have to give blood which matches the patient. So send back samples, that is a coagulation, fibrinogen, blood group cross match, everything, you send it back to the blood bank again. Another thing is viscoelastic test. Does it really have a role? So not all institutes have it. You can use it. It doesn't have any particular mortality benefit. One of the studies which was done is called iTactic. That study didn't show any particular benefit. But it was an underpowered study, so it's not entirely reliable. If you have it, you can use it. So in the end, what are your targets? Targets keep sure with the massive transfusion. Target is temperature should be more than 35. Target Naina less than 1.5, platelet more than 50,000, a normal pH, and at all costs avoid hypocalcemia. They're not really giving any target for hemoglobin actually. Lastly, damage control surgery. What does this mean? It's done in 3 stages. Why would you go about doing a damage control surgery? So patients come to the ER, there is some kind of penetrating trauma to the abdomen, is bleeding like anything. From there itself, you will take to the OT. What you would do is, it's to rapidly stop any major bleeding and control contamination. How will you stop the bleeding? Just ligate it or shunt it or pack it. If you see any intestinal injuries, just clip it or staple it. Then you don't entirely close the abdomen. Just close it with a sheet or with towel clips or something and bring the patient back to the ICU. So the first stage is damage control incubation, where you're just controlling the bleeding, control contamination. Bring the patient back to the ICU. You have to now resuscitate the patient, make sure patient is physiologically stable, avoid the lethal triad. Once the patient is stable, this is the second stage, resuscitation. Once the patient is stable, I'm going to take the patient back to the OT. That happens nearly 24 to 36 hours after the initial insult. And then I'm going to do a planned surgical repair where I ensure continuity of bowel and things like that, and then close the abdomen properly and bring the patient back. This can only be done if the patient is relatively stable. If they are unstable, you can't take them back to the OT. So this is damage control surgery. You have to read about fat embolism and compartment syndrome. I didn't go, it's quite extensive. I don't have the time also. So it's from the ATLS 11th edition, the case-based review. Case-based review is a little outdated, so bear in mind. ATLS 11th edition is obviously the most recent one. Thanks.
Change from the site of major thoracostomy from whole to 50 space to second back to second?
Second, yeah, sir. Now they're saying this is only for needle and the finger.
Then they said that you can put it in the fourth or fifth space anti-accelerate.
Now it is not like that. Put it here. It is changed. You can put it either, but they have emphasized on the second also.